This is a nice thing that people are here. So Tehseen, Mahrukh, and the third one was
Dr. Zainab.
Zainab. Okay. Zainab, Tehseen, and Mahrukh. So who is here? I can see Mahrukh and
Yes,
Zainab.
sir.
Both are here. Good. Okay. Before we start, I would like to say two more things. One, when you are in an exam situation, because I haven't seen you, how you sit, how you talk, how much is your hand movement, you have to focus on some of these things as well. Make sure that when you sit, your back should be touching the chair. Don't sit at the edge of the chair. Completely put yourself in onto the chair, sit comfortably in a static position. Don't move yourself forward and backward on the chair. Make sure that your position is static. Your hand movements can be there. Again, chest can come forward and backward, but don't lean too much. So very important for you, make sure that you are sitting in a right posture. One. Second, the chairs in the exam situation sometimes are here and there, and you have to reorganize them. Make sure that you readjust the chairs. Don't sit wherever the chair is. So sometimes examiner deliberately move the chairs here and there, and sometimes they are in odd position because the previous candidate went away and then he was never able to put the chairs at their place. So the sitting position with the patient, as you have been taught earlier, that should be corrected. You should sit completely on the chair, not on the edge of the chair. Make sure that your hand movements and your chest movements should be back and forth, nothing more than that. And the most important, don't make sure that you keep a distance from the patient, appropriate distance, which again, I don't have to tell you what it is. You all know this very well. Make sure your distance with the patient is appropriate as well, so that examiner should feel that you are in an appropriate, comfortable, distant position from the patient. That is very, very important. Again, as I am not seeing you assessing the patient, so this is important. Then, whatever you want to ask the question, if the patient is a Punjabi speaking person, or if the patient is a Urdu speaking person, or a Pashto speaking person, or a Sindhi speaking person, make sure that you use appropriate conversation methodology with them. So try to communicate with the patient in their language. Of course, in exam situation, they expect you to interview the patient in Urdu, but if the patient is, say, Sindhi, he will be having difficulty in communicating in Urdu always. So the candidates are coming from Lahore going to Karachi for the exam, or from Lahore to Islamabad. There may be a language barrier between you and the patient, so your communication strategy should be modified accordingly. So this is important. Your communication in the patient's language is important. Your sitting position is very important. Your hand movements and your body movements are important. You should be confident, perfect in your sitting, communication in the language, and otherwise. So before you do that, just make sure. And then the last and the foremost, most important component is the timings. You should be wearing a watch, a wristwatch, which can visibly show you the timings. Don't rely too much on the bell. Keep seeing the time off and on in between the interview. So you should know that you have 45 minutes, and at 20 minutes you have to finish this, at 30 minutes you have to finish this, and at 45 minutes you have to finish that. Exam is unfortunately not clearly showing how much skillful you are. It is basically a process, a technology where you are assessed on certain parameters and you have to fulfill those parameters. If you won't be able to, then it will be problematic. So you have to be technically sound in those areas what are expected in the exam situation. Your sitting posture, your hand movements, your distance from the patient, the language you are communicating with the patient, and your, again, comprehensive time management as far as the exam is processed. 45 minutes with the patient, 15 minutes with by yourself writing the summary or formulation or gathering up your thoughts. I know sometimes it is very difficult to write all those things, so I usually don't rely on writing whole of the paragraphs how I'll be talking about it. I usually reorganize my points and then I present it. The presentation is usually recommended not to be reading a paper, but to express yourself very nicely, eloquently, and very professionally, so that the examiner understands that whatever you have done in past 45 minutes is appropriate currently as well. So this is important. Again, I'm telling you these things because I haven't seen you, so I cannot correct you for that. But make sure these are important parameters. Sitting, posture, distance with the patient, communication with the patient, talking to the patient, time management, and controlling the patient as well. So it's not necessary that in 45 minutes you'll be able to do everything as far as the history, mental state, and other physical examination is concerned, but the important parameters needs to be covered. So if a patient, by chance, you are unlucky and you get a patient who is mute, then whole of your interview strategy will be revolving around how you have gathered the information from the patient and in what way it was possible. If the patient is hysterical, dissociative, and she develops a fit in between the interview, then the whole of the situation will revolve around how you have managed that fit and brought back the patient to an appropriate position where she starts talking to you. So these are important things, that it's not necessary that all the patients are schizophrenia or bipolar and talkative and communicative and everything is goody good. No, sometimes there are different patients, sometimes there is a language barrier, sometimes there is a time problem. You have to present yourself professionally, that you know what you are doing and you know how to proceed. Maybe you miss important parameters, that's okay, but you have covered most of the areas. So this is important as far as the things are concerned. Okay. Any questions so far? Anybody? No? Okay. If you don't have any questions, then we can start with the first presentation. I will prefer Zainab or Mahrukh to present first and Tehseen
I
at the
can,
end.
yes, sir, I can present, sir. I'm ready to present.
Good. Okay, Zainab. Let's start and listen to your presentation. Your time starts now.
Assalamu alaikum. So I'm presenting a case formulation of 35 years old Muslim female, married, having two kids. One is 4 years old, other one is 3 years old. She is educated up to 10th standard. She is beautician by profession, but currently not working. Resident of Soldier Bazaar, admitted in psychiatric facility for management purpose. According to patient, she came for the purpose of detoxification of polypsychoactive substance, which include opioid, cannabis, benzodiazepine, alcohol, and amphetamine. According to patient, she was fine in usual state of health 3.5 years back when she developed facial palsy, for which she got treatment for 5 to 6 months. After that, she developed sleep issues agitation, and restlessness. She discussed this issue with her colleague in a parlor, and then her colleague offered her opioid, after which she took opioid, she feel relaxed and become habitually addicted. She used opioid through sniffing. She started using opioid with 1 gram to reach maximum 3 to 4 grams per day. She also smoked cannabis on and off, took benzodiazepine tablets, 10 milligram, 10 to 20 tablets, along with opioid. She also reported to use of alcohol occasionally, and he also reported the use of amphetamine occasionally. But over the course of 3 years, he used opioid more than any other psychoactive substance. Patient also report the episodes of intoxication while using opioid as well as withdrawal symptoms. He report that he was admitted before for the same purpose in a private organization for the purpose of detoxification, but left after 10 days and started the substance again. Patient report the persecutory beliefs against her husband and in-laws. He has also has self-important ideas regarding herself and her abilities and her for future. He report the episodes of low mood as well as increased energy repetitively over the course of 3 years. She also report that he tried to harm herself when he was feeling very low. He tried to burn herself. She has a multiple linear scar marks on both of her forearms. She also report that during the time of increased energy, he had multiple episodes of anger outbursts and physical violence with her husband. She also admit that at that episode, she spent lots of money in substance and other expenditure. No auditory hallucinations has been reported by the patient. Her past medical and surgical history, especially as well as the childhood history of high-grade fever. Family history is significant for the presence of psychiatric illness, as well as the history of substance use in father and elder brother. Family history is also suggestive for medical comorbidity, specifically diabetes and hypertension in both of her parents. Personal history reveals normal birth and developmental period milestones achieved timely, but at the age of 1 year, she developed a high-grade fever. No history of any abuse reported by the patient. She started her school education age appropriately, but couldn't pursue further after matric because of her interest in the parlor work. Um, Her age of menarche was 13. Her monthly cycles were regular with no other abnormality, but patient has been amenorrheic for last 5 to 6 months. She did not report any sexual relationship before marriage. Marital history, she's reported unsatisfactory relationship with her husband. She also reported that she developed some persecutory belief against her husband. She believed that her husband is not faithful with her. She has been physically abused by her husband multiple times. Her husband is also a substance user. He denied any form of conviction or interaction with police. Her premorbid personality, her predominant mode was mostly elated. Her relationship were satisfactory. Her attitude towards religion was okay. She was not very inclined towards religion. Her leisure activities were she likes to work in parlor uh, before her illness. Coming to mental state examination, she was a young age female of good height and thin build. Um, she was kempt. She was wearing shalwar kameez. She was distractive. She walked out 3 times during the interviewing, but on insistence, she came back and agreed to continue the interview. She was making and maintaining eye contact, but he was very non-cooperative throughout the interview. Rapport was established with difficulty. Her speech was very pressure, over spontaneous, over inclusive, tone and amount was slightly increased. Her mood was elated, effect was congruent. Um, Flight of ideas has been observed in her thought form. There's no perceptual disturbance, no suicidal thoughts were present, no obsessive and compulsive thoughts were present. Coming to cognitive functions, her attention and concentration was decreased. He was unable to do the serial 7, but when asking about the days of the week in backward counting, then he was able to do that. Her short-term as well as the long-term memory was intact. He seems to be oriented to time, place, and person. Her abstract was intact. Her judgment was intact. Her insight seems to be absent. On journal physical examination, during inspection, generalized pallor, poor oral hygiene, and multiple linear scar marks were present in both of her forearms. During the motor examination, her bulk, tone, and power was normal, but reflexes were slightly increased. Patient was reported constipation, increased sensitivity to cold, decreased sleep, decreased appetite. But during the thyroid examination, there was unremarkable. Um, Based on my history, mental state examination, and journal physical examination, my first differential is organic brain syndrome. My second differential is mental and behavioral disturbance secondary to polypsychoactive substance use. And my third differential is bipolar affective disorder, currently manic episode. Now, sir, coming to etiology, predisposing factors, may, sir, I would like to put the genetic factors, especially the family history of psychiatric illness. Precipitating factors, may, sir, I would like to put the comorbid substance use, her sleep deprivation, her intermittently medical illness. She reported report incident of dengue a few weeks back. Her perpetuating factors, may, sir, I would like to put the continued substance use, medical illness, and continued psychosocial stressors. So coming to management, I would like to manage this patient according to biopsychosocial approach. So my biological approach would be that I would like to admit this patient. My immediate concern is to provide her prevent harm by providing her safe ward environment. I would like to take a collateral account from family, especially husband and her siblings, her parents. I would like to take his previous medical record, her previous investigations, treatment record, and response to dose treatment. Um, then, sir, after then I would like to send baseline investigations like CBC, UCs, LFT, PTINR, viral markers. So I would also like to send his spatial investigations like thyroid function test and lipid profile. And I would like to send her prolactin, serum prolactin. I would also like to send his beta HCG. I would like to send her urine toxicology. On the basis of the result of those reports, and after ruling out organicity, I would like to observe this patient uh, to rule out either it is because of psychoactive substance use or because of a bipolar affective disorder. So if patient, I would like to admit this patient, observe this patient for 28 days, and after that, I would like to repeat his urine toxicology. On the basis of that, if no substance will found on a second test of urine toxicology, then my management would be to start antipsychotic. Like, sir, in this case, I would like to start with second generation antipsychotic, as patient already report that he has been amenorrheic for last 5 to 6 months. And if this is second due to a increased prolactin level, so I would like to avoid those antipsychotic which will increase the level of prolactin. Specifically, I would like to start either with aripiprazole or quetiapine. So after that, I would also like to apply the opioid withdrawal scale to assess her withdrawal symptoms and manage those symptoms symptomatically. I would also like to um, family intervention, work on a family intervention and compliance therapy. I would also like to enroll this patient on occupational therapy to maximize her functionality and work on her motivational interviewing. So, coming to prognosis, in this case, there are the favorable factors as well as non-favorable factors. Unfortunately, the non-favorable factors are more than the favorable factors. But I will start with the favorable factors, like there's no psychotic symptoms are present. The onset of illness was sudden and precipitated by an event. Duration is duration is short, and mm, uh, insight was present, while there are the unfavorable factors like there's a continued substance use was present, her psychosocial stresses was continued, family history and genetic history is very strong. So, so that's all from my side.
Okay. Zainab, should I start asking questions?
Yes, sir.
Okay. Three things remember. Whenever there is a substance abuse, number of the days in hospital or that is important. The major mistake that you are doing, and I'm sure it is lots because of your anxiety presenting in front of so many people. This happens in the exam situation as well, but you have to correct it. The gender of the patient. Sometimes you are using he, sometimes you are using she. Make sure that you keep on using she, not he.
Ji sir.
Okay? Okay.
Ji sir.
So make sure that your expression of the gender, she, should be continuously used. There were a number of times when you said he is having this and he is having that. No. Try to keep yourself focused. This actually shows that you are get a little bit anxious in presenting. Keep yourself calm. You are doing perfectly fine. There is nothing wrong with it. All you have to do is to remain focused. Then some of the times you were using the words was good, was bad, was good, was bad. Don't use these terms. The good and the bad words, usually at anywhere, like cognitive functions are good. No, this means that it's very judgmental opinion. It's your opinion. Always use the parameters. So the cognitive functions are within normal range, or the biological functions are within normal range. Don't say they are good or they are bad. Okay. Now the
Ji.
question is that your diagnosis is organic brain syndrome number one. What is that?
So because her symptoms preceded by a febrile illness, after the febrile illness, so
So what
after
are you
ruling out.
considering?
Sir, my working diagnosis will be mental and behavioral disturbance secondary to psychoactive substance use, but after that, ruling that organicity.
Well, again, ruling out organicity, you said probably she developed a febrile illness. So you are thinking of post-encephalitic?
Um,
Are you considering post-encephalitic? Because febrile illness ke baad, what is the most common situation? Delirium,
yes,
viral infection, post-secondary
the
and
viral,
viral infection, encephalitis, right?
yes, sir, post, G, yes, sir.
Now, if you are considering post-encephalitic situation, the only positive finding that you have mentioned in your presentation is the brisk reflexes,
Yes, sir.
nothing else. Cognitively, she is fine, she's communicative, so there is nothing like that. So if you consider the organicity here in this situation, yes, you have mentioned it in the top priority as number one, but you have to mention the word that you have used or yourself My working diagnosis for management strategy is again disorder secondary to the substance abuse. That will be the appropriate one. Now, if I consider that this is a substance abuse disorder, mental and behavioral symptoms secondary to substance abuse, fine, I will proceed with it. Now, the point is, if it is mental and behavioral disorders secondary to substance abuse, you are considering opioids. What opioids?
So powder in the form of heroin.
Okay, heroin and what
Yes,
else?
heroin.
How she was consuming heroin
He used through sniffing.
and what is she doing now?
He
Is
still used
she
it.
is she injecting herself?
No, she's not injecting. He
Okay,
never used any IV route.
so she is still either sniffing or doing what? Some other methodologies, but not injecting, right?
Yes, sir.
Okay. And when you said investigation, viral markers, what do you mean by viral markers?
So viral markers to rule out, because he also has a history of alcohol. So for viral markers, I would like to rule out the HB, hepatitis B and C.
Okay. Will you try to rule out HIV as well?
Yes, sir. I forgot to mention, but I also would like to send her HIV
Okay.
profile.
And the reason being that because of the substance abuse and other history, you will try to get more account about her sexual
Yes,
issues and maybe rule out the other as well. But for that, you need the consent of the patient as well.
yes, sir. After taking her consent.
Exactly. You have mentioned in your mental state examination abstract thinking. What do you mean by that? Why do you need an abstract thinking in a patient with a substance abuse?
Sir,
So, abstract thinking was again one of the methodologies which was done on mental state examination 15 years ago. Now, nobody across the globe does abstract thinking on mental state examination, so don't mention it. It's an old school of thought. Now things have changed. Scientifically, they have assessed that assessing abstract thinking is difficult. Abstract thinking after assessment, you are still not sure what will it lead to the diagnosis. So it is not mentioned in the mental state examination. Don't do that. पुरानी चीजें भूल जाएं. Just keep the things which are recent most. Don't mention it. Then you said that I will prescribe her antipsychotic. Why not mood stabilizers?
जी सर। सर उसके लिए ये कि मुझे उसका प्रीवियस ट्रीटमेंट रिकॉर्ड नहीं पता, तो एक तो वो ट्रीटमेंट रिकॉर्ड मालूम करूंगी, उसके बाद उसका रिस्पॉन्स देखूंगी, क्योंकि नॉन कंप्लाइंस भी रिपोर्ट हुई थी कि दवाएं खाती थी फिर छोड़ देती थी। तो पहले फर्स्ट लाइन एज एन एंटी साइकोटिक स्टार्ट करके कंप्लाइंस को मेंटेन करके फिर देखेंगे। अगर उस पर रिस्पॉन्ड नहीं आता, देन माय सेकंड लाइन वुड बी टू ऑगमेंट और एड mood
Patient
stabilizer
is
along with,
already taking so many benzodiazepines, right? And if you
yes,
will admit her in the ward, there will be the withdrawal of the benzodiazepines and withdrawal of the substance she is abusing as well. How would you like to manage that?
so I would apply the scale first to assess the
So
baseline.
she is. This is what the history is. She is abusing substances. So how
So
would
फिर
you like to manage her for first few days in the ward?
so,
Benzodiazepine withdrawals, she may develop a seizure. What will happen then? So how would you like to proceed with it?
so I would go for dose reduction
Off.
of benzodiazepine.
So you will
She's
continue the benzodiazepine.
I would taper off gradually.
Right. So this is what I'm asking. So if you don't want to start her on a mood stabilizer or an anticonvulsant, you have to give something in the ward to make sure that the substance abuse withdrawals and benzodiazepine withdrawals should not impact her. She will be more delirious then, right? So you will
Yes.
give an SOS benzodiazepine or a high dose of benzodiazepine with a taper off schedule and gradually get rid of it, right?
Yes, sir.
Now, this is another long discussion. I don't want to go that way, how to taper off the benzodiazepine and what needs to be done, but I'm sure that you know that. You said there is a history of a self harm. Have you tried to assess if she is suffering from substance abuse and personality disorder?
Yes, sir. If I will get a time or patient being little more distractive at that time, I was unable to elicit her personality. But if I will interview her again, I will definitely assess her personality. There were
Okay.
definitely the
Now,
some
Zainab,
personality.
you have to mention this in your management strategy that you will definitely try to administer the personality scales or the assessment of the personality and keep the consideration of borderline personality disorder or some other personality disorder in your assessment and management strategy. Don't miss it. Most of the
Yes,
substance abuse people, they do have some personality issues or some other psychiatric morbidity as well, which I'm fine with it, whatever you have mentioned, but don't miss this word. If I'll have more time, this is what you said. I haven't said that. If I will have more time, I will reassess the personality and I will try to give her some personality scale to assess the personality absolutely, which makes sense. Of course, in this short time, you won't be able to do that, but you will consider it, right?
yes, sir.
Okay, good. Your speech was fine. Otherwise, you are okay. But make sure that you correct your deficiencies that I have mentioned. He, she का जरा ख्याल रखना, ठीक है?
जी.
और बाकी चीजें हमने डिस्कस कर ली हैं. Good. Keep it up. Keep working on it. And as I mentioned to you earlier, when you are sitting on a chair, make sure that your posture is fine. You don't look very anxious. The he she difference again shows that you are getting anxious. Don't control yourself in your presentation. वो ड्रामा जो है ना वो आपका इम्तिहान में यही लगे कि इससे ठंडा साइकियाट्रिस्ट तो है ही कोई नहीं. सो अपनी एंग्जाइटीज को मास्क करना है in whatever way possible. This is the only way. So the presentation should be with confidence. Okay?
ठीक है, sir. Thank you, sir.
Good. Shabash. Now, Mahrukh, go ahead.
हेलो अस्सलाम वालेकुम सर.
वालेकुम अस्सलाम.
जी सर, आवाज़ आ रही है सर आपको सर?
बिल्कुल आ रही. Go ahead.
Okay sir. Okay sir. My patient is a 28 years old male, Mr. Iqbal, who is resident of Thatta. He has been married for 9 years and father of 2 kids. He is educated till grade 8. He is a driver by occupation and he was admitted voluntarily from OPD with complaints of substance use, that is cannabis, for the past 10 years, and also irritability, low mood, and anhedonia for the past 15 to 20 days. He has been addicted to cannabis and until recently he had been smoking 18 to 20 cigarettes of it per day. His, his use was gradually increased since the onset and he never tried to reduce or stop it before. And last dose was taken a day before the admission. This is his first day of admission. For the past few days, he had also been experiencing increase in his irritability and gets angry over little or no provocation to the extent of verbal as well as physical abuse. There are several incidents of fights that have been reported in which he had injured other people and he did but also he did feel guilty and remorse after such incidents, and also various times he asked pardon from the victims too. Besides, he had also been feeling low mood almost throughout the day and finds his usual activities less appealing to carry on. He also reports of fatigue as well as lightheadedness upon working on his routine task. But there is no history of hopelessness or any history of self-harm. There is no disturbance in biological functions that include his sleep, appetite, libido, or bowel habits, as well as his concentration or memory. There is no report of feeling elated or high in energy for the past few days, and there is also no history of any psychotic symptoms. These symptoms of anger and low mood have been troublesome for him, and to counteract these, he consumes cannabis to stay calm and peaceful throughout the day. His past history is positive for the alcohol he used to use for about past 15 to 20 years back. He used 15 to 16 glasses of local wine, that is known as Thurra in his normal language, and also 2 pints of whiskey daily. He sought detoxification treatment for this in the hospital and stopped it, but a month later he started it with the cannabis. He has stopped alcohol, but he is currently on cannabis only. He also gives history of depressive symptoms with suicidal ideation at that time when he was admitted for the alcohol detoxification. The stressor was related to a romantic relationship, after which he started alcohol for his own relief. Also, he used tablet lorazepam, the dose of which he could not remember, and also gutka along with his alcohol. There is no history of any event of intoxication or any history of medical admission or any surgical issue. But he had been admitted once in the psychiatric hospital for alcohol detoxification that I already mentioned, and had consulted psychiatry or a psychiatrist on OPD basis several times for his mood symptoms. Recently, he was taking sodium valproate, that is 500 mg BD, and also haloperidol, that is 10 mg in divided doses, that is BD, and also procyclidine 5 mg once. That has been started for a few days back by his treating psychiatrist, but then the same psychiatrist advised him to get admitted inpatiently. His forensic history is positive for being imprisoned about 8 to 10 times for the violence against people. About an year back, he was condemned for the death of a person via RTA. He said he hit him with his car in anger, and he was not under the influence of any substance at that time. And also about 7 months back, he had shot a person, but that person was saved in a fight with his other friends. Besides, he claimed to be involved in snatching and robberies with his similar friends in his early adulthood. He had early access to weapons, easy access to weapons through his friends that are involved in such crimes too. I consider him to be at high risk of violence, but he had no history of planned violent acts or homicidal tendency, and also there were no such tendencies at present in his mental state. His personal history also revealed him to be of impulsive and short-tempered in nature since his childhood, but there are no significant incidences of violence reported in his childhood or even in his adolescence. There are history of multiple relationships as well as superficial friendships that are intense but very short-lived. There is history of sexual contacts, positive, extramarital affairs with the females. He is caring towards his family members, but not towards other relatives as well as neighborhood. And also the locality belongs mostly to the people belonging to the criminal offenses. There is no history of psychiatric illness in the family. Upon MSc, he is a young male, average height, thick build, confident, maintaining eye contact. Rapport was established and he appears to be camped. Mood, although subjectively he reported of low mood and depressiveness symptoms, but objectively I consider him to be euthymic. His speech was normal toned but increase in volume. It was relevant but over-inclusive. Thought he was preoccupied with his anger issues, but there were no delusions, there were no suicidal or homicidal thoughts, there were no obsessive thoughts. In perception, I couldn't find any hallucination. In cognition, he was oriented to time, place, and person. Attention and concentration and memory were normal, as well as judgment was normal, and insight was also present. According to this, and also my general physical examination seems to be normal. He was vitally stable. and there were no history or any significant findings on his GPE. Based on this, my provisional diagnosis is, according to ICD-11, disorders due to substance use, that is cannabis-induced mood disorders. The point in favor is a history of cannabis that is of heavy use for continuous duration, long time. Mood symptoms of irritability and low mood are present after the onset of substance use. But in my DDs, I will also keep bipolar disorder type 1, current episode mixed without psychotic symptoms. The points in favor are low mood and anhedonia with the history of increasing impulsivity, aggression, and also there were MSE findings of increased confidence and increased speech. But there is no evidence of any delusion, hallucination, or any psychotic symptoms. And also there is history of previous depressive episode. But there is a point against, that is, I am finding the relationship with the substance use, and the depressive episode there was alcohol, and now he has been consuming cannabis on the daily basis. On my second differential, I would like to keep personality disorder, severe with dissociality and borderline pattern. But the point against is a history of again substance use and the temporal relationship with the substance use pattern. In my etiology, I would like predisposing factors of male gender, being young in age, vulnerable personality traits, as well as vulnerable environment. The precipitating factors is a history of substance use, associated relationship stressors. In perpetuating factors, there is non-compliance to the treatment reported, and also there are social and environmental contexts too. In my management, my working diagnosis is substance abuse, that is cannabis-induced mood disorder. In investigation, at first, I would like to look at his previous medical records. And also in biological investigation, I would go for routine blood tests that include CBC, urea creatinine electrolytes and LFTs, and also for the thyroid levels, as well as B12 folate levels, and HIV and hepatitis C viral markers, because he is giving history that is positive for the sexual contact. Also, I would order a urine toxicology and the BMI of this patient. In psychological investigation, I would like to go for a formal personality assessment, and also I would like to go for withdrawal assessment for his substance use by applying a scale that is cannabis withdrawal scale. In social investigation, I would like to go for a collateral account, as well as reviewing the previous treatment as well as medical and psychiatric records. So my treatment, in biological treatment, since he is already on haloperidol as well as valproate, I would like to know the exact doses, and I will optimize them. And I would like to check the response of this patient on the maximum tolerated levels of these drugs. But also I would like to give a short-term trial of benzodiazepine to calm the patient, because he had been reporting irritability and anger issues. In psychological management, I would like to go for the psychoeducation to the family as well as to the patient, supportive psychotherapy, and in the long run, I would also like to go for CBT, the group therapy for his substance use, and also dialectical behavior therapy, interpersonal therapy, and interpersonal social rhythm therapy. In social management, I would like to ensure a safe and sound environment, calm environment for this patient, since he is at a high risk of violence. Proper staff nursing is needed for this patient. Occupational training is required, and also exercise is involved. Again, he could be involved in exercise programs. According to me, in prognosis, there are certain factors that are pointing towards the bad prognosis, that includes his male gender, continuous substance use, evidence of depression, and vulnerable personality traits. However, adequate treatment and compliance may improve the outcome in this patient. That's all, sir.
Good. Okay. So, generally speaking, आज substance abuse का दिन है. Okay.
Yes, sir.
What is the drug treatment for cannabinoids?
Sir, cannabinoids does not cause any physical dependence. So basically, the drug treatment is focused on the psychological factors that the patient experiences. For example, this patient has been experiencing irritability and anger issues, so we can put him on the antipsychotic or a mood stabilizer.
Right. Now, he is already on 10 milligrams of haloperidol. What is the optimal dose of haloperidol currently in practice?
So we can go for 15 to 20 mg.
अच्छा, haloperidol 80% receptor occupancy कर देती है 7 milligrams पे.
Okay, sir.
So वो थोड़ा सा देख लीजिएगा. He is already on a mood stabilizer divalproex 1000 milligrams. What is the optimal dose of divalproex?
Sir, according to the Maudsley guidelines, the adequate blood levels are 125 mg per liter for the treatment response in acute mania.
Okay. And have you got the valproate levels for this patient?
No, sir, I couldn't, but I would keep in mind if they are available, we can
So you
order
will
the
go for
valproate
the
level.
blood levels if you really want to do that. Otherwise, clinically, you can adjust the dosage.
Yes.
Whosoever was the treating psychiatrist, definitely I would like to take his accounts, because antipsychotics for anger issues won't be a very good option. Of course, we have to assess whether this person was really having some psychotic illness before the onset of illness, why haloperidol was initiated. So that is one domain that needs discussion, but I won't touch that. But generally speaking, he is having lots of problems like anger issues, homicidality, suicidality in the past, not now. Of course, you have mentioned it. He was involved in crimes and thefts and extramarital relationships, sexual relationships. So, do you consider your primary diagnosis, because cannabinoids don't need any treatment as far as the biological treatment is concerned, it's more psychological. Would you consider the personality disorder as your number one diagnosis?
Sir, I may consider it, but I need a proper collateral amount and a proper history for proper psychological assessment for this patient.
If this patient is suffering from personality disorder, will you continue the divalproex, haloperidol, and procyclidine?
So for personality disorder, currently there is no recommendation for pharmacological management. Basically, it is psychological, but since the patient has been reporting mood issues and increased anger and irritability, can go for mood stabilizer treatment.
There is some evidence
suggested by various guidelines.
There is some evidence of 4 medications that can be used in personality disorders which are unmanageable. Can you name any of the 2?
He can be put into on valproate.
Okay. What else?
And olanzapine or
Sorry, आवाज break हो गई. You said olanzapine and
butadiene.
Butadiene. Okay. Usually, lithium is one of the drug which is time tested, and they say that it can help in some kind of the personality issues. And there are few research papers available over the period of years which recommends that lithium can be a good drug in some of the personalities where anger and other profiles are there. Just go through that. One is lithium, second is olanzapine, and third is fluoxetine, depending upon the presentation of the person currently. Now, if he is admitted in the ward, and you are admitting him in the ward as the patient is admitted, how long you want to keep him there?
Yes, sir.
Sorry, Maruf, आवाज break हो गई. How long would you like to keep him there?
On his. Hello.
Yes, please go ahead.
Ji sir, I would not keep a long admission for this patient. Once he is stabilized on his mood issues, I would like to discharge him and keep him on outpatient basis treatment only.
How long?
Sir, outpatient treatment continued as long as the patient
Inpatient. I'm
feels.
asking inpatient. How long would you like to keep him in inpatient psychiatry?
So for a week.
Okay. Why a week? What's the rationale of keeping him for a week?
Sorry, sir, I don't know the rationale.
No, you know the rationale, but you are not coming up with it. So the rationale is one, cannabinoids usually wash out from the system in 24 to 48 hours time, but they stay in the system for almost 3 to 6 weeks time. As soon as the levels drops down in 24 to 48 hours time, usually patients, most of the patients who are having cannabinoids abuse and having presenting with these kind of symptoms, they do settle down. And second, your assessment. If you will be able to get the investigations, get the personality assessment and other psychosocial assessments along with objective assessment of the patient, collateral information, then of course, once establishing the diagnosis, you don't have to keep him for long in the hospital. And the long-term management plan will be on the outpatient department. Okay, good. This is overall, it's okay, it's fine. In most of the time in exam situation, if a person is having a substance abuse patient, they are difficult patient as far as the exam is concerned. The more difficult patient, like schizophrenia, catatonia, bipolar, mania, the examiners are usually they interact with you and you interact with them, and it's relatively easier. With substance abuse, they ask too many questions. And when there are too many questions, then the chances of interacting with the examiners for so much may be compromised. So that's a tricky situation. Substance abuse सवालात इतने ज़्यादा हो जाते हैं और उसमें फिर obviously arguments भी होते हैं. There are different viewpoints of examiners how to treat substance abuse because it depends on your training. So some people train in more psychodynamic again setups. They talk more about the psychological management of the substance abuse. So उस पर discussion लंबी हो जाती है. और जो biological methodologies पे treatment strategies पे जिनकी training है वो biological methodologies पे ज़्यादा focus करते हैं. Be careful and be prepared that if you have a substance abuse patient, there will be a lot of questions. मैंने इतने नहीं पूछे क्योंकि मैं डराना नहीं चाह रहा, लेकिन सवालात बहुत ज़्यादा पूछे जाएंगे. Okay? Good, very good. Just continue with it. Make sure that your gesture, posture, interaction with patient, time management is appropriate. Okay?
Okay, sir.
Perfect. Now,
Thank you, sir.
Tehseen.
हाँ
Are
जी
you
सर.
there? Are
Yes
you
sir,
there?
I'm here. Yes sir.
Okay. So go ahead. तुम्हारा भी patient substance abuse का तो नहीं है?
नहीं सर, ये नहीं है.
अच्छा, मैंने कहा आज substance abuse day है. Go ahead.
Sir, this is case formulation of Mr. XYZ, a 51-year-old primary past father of 5 children, butcher by occupation from Multan, admitted involuntarily through psychiatric OPD 1 week back on request of his family for the management of worsening of his chronic psychiatric illness. Reportedly, he was in his usual state of health 15 years ago when he insidiously experienced fearfulness gradually increased in the form of paranoid delusions, especially of persecution and infidelity towards his wife. He started refusing to take food from his wife, rather took food from his sister's house. Multiple times he got into physical scuffle with his wife and children on account of infidelity. Family consulted initially with local psychiatric facility and he was prescribed with risperidone 4 milligram in divided doses. However, illness ran remitting in relapsing course on account of poor drug adherence. And recently he is on long-acting antipsychotic flufenazine 25 milligram fortnightly along with oral antipsychotic risperidone for the last 3 months. No extrapyramidal side effect or metabolic syndrome reported. No history suggestive of any head injury, Hakim medications, illicit substance use, especially alcohol or cannabis, low or elated mood, obsessions reported by the family during the course of this illness. For the last 1 month, his symptoms worsened on as he tried to axe his wife and children. However, fortunately, his family was survived by family interventions, and now illness has deteriorated his personal, social, and occupational domains of life severely. And no family, after this incident, when he tried to homicide his wife, uh, his family sought psychiatric in-unit treatment. Past medical history is suggestive of psoriasis for the last 15 years, but the treatment record is unavailable. Past psychiatric history is unremarkable. Past family history, his mother died of cancer, and he thinks that his mother was poisoned by his family. And although he proceeded through normal grief reaction normally, high expressed emotions within the family in the form of neglect are pertinent. And he belongs to a poor socio-economical status. And no psychiatric illness or substance use or homicide or suicide reported within the family. Personal history is pertinent for marital disharmony, sexual dysfunction. However, I would like to further assess from the second partner, from his partner. And he socio-economical status are constraints because he belongs to a fragile economical status. And forensic history is unremarkable. However, I would like to further explore in my management plan. Pre-morbidly, he was extrovert, sociable, having good long-standing coping skills with no impulsivity, eccentricity, suspiciousness, magical or illogical thinking in the past. However, he used to consume nicotine, and currently he denies using any illicit substance use. However, I would like to further get detailed account of substance use and personality from family informant. Physical examination is pertinent for psoriatic marks on both arms and legs, pallor, oral thrush. However, he is vitally stable currently with no cyanosis, clubbing, thyroid enlargement, and his systemic inquiry is within normal range. On ministerial examination, he is having compromised self-care, preoccupied with delusion of infidelity, and persecution through poison from his wife, and ideas of homicide to his wife with impaired insight and judgment. However, there's no obsession, disturbance in thought of alienation, insertion, and passivity phenomena with intact perception, memory, and risk assessment. Homicide risk, according to history and examination, is moderate to severe. On multi-axial classification on axis 1, according to history, physical, and ministerial examination, my most provisional diagnosis is, after ruling out organicity, according to ICD-11, is delusional disorder 6A24. Points in favor: circumscribed delusions, non-bizarre in nature, and with no persistent hallucination, no disorganized thinking in the form of loosening of association, and absence of depressive, manic, or mixed episodes. And not associated with brain tumor steroid use. But however, I would like to further explore the use of steroids for psoriatic purpose in my management plan. My first differential would be organic psychosis. Points in favor: skin lesions in the form of scaly silver-like lesions, likely psoriasis, and points against: I have no record currently about using of steroids. My second differential would be schizophrenia. Points in favor: paranoid delusions, disturbed personal interpersonal functionality. Points against: no perceptual abnormality, and age of onset is of 40, more likely middle age, and the delusion is circumscribed and non-bizarre in nature. Second, my third differential would be schizoaffective disorder. Points in favor: delusions and fearfulness and delusional mood in the start. Points against: no definite criteria for mania depressive episode met during the course of this illness. On access to functionality in personal, social, and occupational domains of life have been compromised, graded as 3 by 5. On access 3 etiology, my patient was predisposed to this illness due to male gender, favorable age, marital disharmony, and sexual dysfunction, and precipitated insidiously and maintained on account of ongoing difficult relationship with his wife, nature of the illness, lack of education into the illness, poor compliance with medication, and untreated sexual problems. Management. In management, I would like to admit my patient looking into serious nature of his risk of homicide. I would like to make therapeutic alliance, and in my immediate concern, it would be to ensure safety of the patient and the family through psychoeducation, through separately removing any potential harmful objects from the patient, and verbally de-escalating the patient that he is safe here, and providing him non-provocative environment. And I would like to get detailed account about the level of conviction, about the risk of homicide from the wife as well, from his wife as well. Further, after ensuring safety, and I would like to manage my patient on biopsychosocial model. In biological assessment, my short-term goal will be to get medical record and use of any steroids and response of previous antipsychotic and the dose of that antipsychotic. And I would like to further send all baseline investigations, including complete blood count, liver function test, renal parameters, blood sugar random, serum electrolyte, fundoscopy, and urine drug screen. And I would like to, in biological short-term treatment, I would like to continue risperidone, which was being used in previously, that is 4 milligram in divided doses, along with procyclidine. And I would like to continue the long-acting injections, which was fluphenazine 25 milligram fortnightly, while monitoring side effects and the effects, and also sharing the choices with the patient, and agreed choices from the patient, getting agreed choices from the patient. And I would like to get liaison with dermatology department for the management of psoriasis, and while avoiding the oral use of steroids if it may be. In psychological assessment, I would like to assess the severity of delusion through using brief psychiatric rating scale. I would like to see the severity of delusion. I would like to see the risk of homicide, and through using violence risk appraisal guide. And I would like to see any cognitive distortion. And in psychological short-term management, I would like to psychoeducate the patient and the family regarding the nature of the illness, course of the illness, probable treatment options, and possible stay over here, and the risk of homicide in my client, and how to manage that client, that homicide rate. And I would like to work on compliance counseling. I would like to decrease the high expressed emotion, and through family counseling. And in social short-term assessment, I would like to assess the level of support from the wife, family, and finances. And I would like to, in short-term social treatment, I would like to enhance the support from the family in a non-confronting approach to not to provoke the risk of homicide in my patient. In intermediate goal, I would like to continue risperidone along with the long-acting injections, while if after 2 to 3 months, I would like to switch to long-acting injections on adequate doses, and I would like to gradually taper off the risperidone, and while monitoring the side effects. In psychological intermediate goal, I would like to continue psychotherapies like CBT, interpersonal psychotherapy, family counseling, and couple therapy. And in social intermediate goal, I would like to sustain the support of the family and friends and finances to maintain the recovery in my patient. A long-term biological goal would be, I would like to continue the long-acting injections for 1 year, and while monitoring the side effect and adherence. And I would like to check any signs of relapse, and I would like to maintain recovery in my patient, sustain the recovery in my patient, and I would like to continue CBT, interpersonal psychotherapy, and couple therapy in long-term goal. In social management, I would like to work liaison with the social welfare department for the availability of free medication to my patient. My goal of this treatment would be 1 year initially, and however, I would like to continue according the risk of relapse or and according to my response of the treatment. In prognosis, short-term prognosis seems to be good as my client is admitted and family is motivated. And at tertiary care hospital, we are all having psychotherapies and all management strategies. But long-term prognosis has dual prognosis, like it may have some good prognosis factors like non-bizarre delusion, and he is motivated to be admitted.
Wait, sorry, I'm cutting you. Three things. It is always very good to hear you, but try to keep yourself for 15 minutes presentation, which is good. So far, you haven't made any mistake. I had some queries and you kept on answering to the same queries that I was listing, so which is a good thing. The patient's onset of the history as reported by the family is somewhere between 35 and 40 years of age, which is very unusual for schizophrenia, but it's not unusual for a delusional disorder. So you mentioned that. You gave me the diagnosis along with this thing. You said he was having delusions in the past. Have you ever checked him for delusional memory or any other primary delusions?
No, sir. I was having short of time, so
delusional
I
perception, delusional memory. Have you ever checked any one of them?
Yes, I checked delusional perception.
And it something was there or was
yes,
not?
It was not present, sir.
Okay, because if there is a primary delusion, delusional memory, delusional perception, then of course it goes more in favor of schizophrenia, and probably the onset description is not appropriately mentioned by the family. Probably the onset was much earlier, but they were not bothered about it because he was not having any problems with it. But after getting married, the problems initiated. There is a social occupational decline in this patient as well over the period of years. And usually the delusional disorder people, they don't have much of the social and occupational decline, but it's much more seen in patients suffering from schizophrenia. So that also goes in favor and against if you get the details of it. He is having sexual problems. Don't you think that the risperidone is causing the sexual problems and you don't want to address that?
Yes, sir. Of course, it causes retrograde ejaculation and sexual dysfunction. So then I would like to.
You never mentioned about that you will try to push up the dosage. The risperidone was given 4 milligrams per day in divided dosage. Is there any rational use of dividing the antipsychotic dosage?
No, sir.
Right. So the divided dosage goes away. If I'll be treating him, I will give him 6 milligram risperidone only in the evening. It improves the compliance. It improves the adherence. It is better, less of the side effects, and probably patient starts feeling better as well. So try thinking on those lines as well. If you will maintain him on flufenazine, then of course, what is the maximum tolerable dose of flufenazine?
So almost 100 mg to 125 milligram.
How many days?
Sir, I would like to start starting from 25 milligram fortnightly.
He is on 25 milligrams bi-weekly. How much you want to give?
Currently, he is using 25. I would like to increase to 50, starting from the 25, then 50 milligram, and then increasing according to the response of this treatment. I would like to.
This is the catch. He is having sexual side effects with the risperidone. We can taper it off because First thing, the trial was never complete. It never went up to 6 to 8 milligrams per day. So I won't say that the trial of the risperidone was complete. Second, flufenazine is in a very low dose. This is what the practice is. Most of the time, you never push up that flufenazine to 25 to 50 to 75 or 200. It can be given 100 milligrams to 125 milligrams every 2 to 4 weeks, depending upon the tolerability and the thing. So one monotherapy is recommended. It will improve the compliance as well. Last question. If you want to change the antipsychotic, considering the diagnosis to be, again, delusional disorder, not schizophrenia, what will be your choice?
Then I will start with aripiprazole, sir, having less
Okay.
metabolic. Yes.
But again, aripiprazole is not available in injectable form, and the compliance
Yeah.
will be an issue.
Exactly, sir. Exactly.
Any other choice?
Zuglupenthixol, that's available in Pakistan, which
Yeah.
is
Flupentixol or zuclupentixol?
flupentixol and
What is the difference between Zuclo and Flu?
I don't remember that
Sorry, फसाना
exactly.
मकसद नहीं था. Sorry, फसाना मकसद नहीं था. मकसद था कि तुम्हें इस किस्म के सवाल एग्जामिनर पूछ सकता है. जब कैंडिडेट अच्छी प्रेजेंटेशन कर रहा हो तो उसको तंग किया जाता है. Don't bother about it too much. Don't panic. Okay, flupentixol or clopixol or flumzol? तुम्हारी चॉइस क्या होगी?
Flupentixol, sir.
क्यों?
And because it works on serotonergic pathway.
नहीं, इस पेशेंट के हवाले से क्यों? हिस्ट्री में क्या बताया? हाँ,
सर सेल्फ केयर कंप्रोमाइज थी तो नेगेटिव सिम्टम्स को भी सर ये कैटर कर लेगा इसी हद तक.
इफेक्टिव कंपोनेंट को कैटर करता है, और उस इफेक्टिव कंपोनेंट को कैटर करने के लिए फ्लूपेंथिक्सॉल यूज करोगे, लेकिन अगर इफेक्टिव कंपोनेंट नहीं है तो क्लोपिक्सॉल यूज करोगे. और डोज उसी तरह, फ्लूपेंथिक्सॉल की डोज इज approximately, test dose is 20 milligrams and you can go up to 100 milligrams every week. Maximum tolerable dose should be adjusted and response to be seen. Okay?
Thank you, sir.
Good.
Thank you.
Keep it up, all of you. I'm sorry I have to rush out now, but I liked it because all the three presenters were good. They were focused. Make sure that you don't get anxious. Exam is a technical thing. It's not actually the marker of your clinical and personality skills. Some people do very well in exams, but they are pathetic psychiatrists in future. Some people do very bad in exam, but they are excellent psychiatrists as far as their clinical skills is concerned. So it's not unfortunate, it's very unfortunate, but this is not true that all good psychiatrists pass the exam. It's something like, technically, if you are sound in your presentation, in your vocalization, in your assessment, in your professional attire, you pass the exam. This is how it works everywhere. It's not in Pakistan, it's globally the same. So best of luck, all of you. Make sure your anxieties are controlled. You are professional, you are methodologically sound, and you utter everything appropriately. We hope that abhi date announce hogi. Anybody? हाँ?
अभी नहीं हुई अनाउंस.
अभी नहीं अनाउंस हुई. अगर डेट अभी अनाउंस नहीं हुई तो इंशाल्लाह हम एक दफा फिर मिल लेंगे, और जिसने प्रेजेंट करना हुआ दोबारा से कर दे. वंस डेट अनाउंस हो गई, देन आई वोंट कंडक्ट दीज सेशंस, बिकॉज आप लोगों की एंजाइटी को मैं बढ़ाना नहीं चाहूँगा, उसको रिलैक्स करना चाहूँगा. ओके, बेस्ट ऑफ लक, अल्लाह हाफिज, सी यू अगेन.